I'd like to introduce the first speaker for our clinical panel, and that's Dr. Amy Justice. Dr. Justice is a graduate of Harvard University and Yale University School of Medicine, and holds a PhD, from Wharton School at the University of Pennsylvania. She is Associate Professor of Medicine at Yale and a Principal Investigator for the VAC study, the Veterans Aging Cohort Study. For more than 20 years, Dr. Justice has studied outcomes in chronic HIV infection with the intent of using HIV as a model for improving outcomes in chronic disease. She's published more than 100 papers related to this work and served on 20 expert panels focused on improving outcomes, clinical outcomes in HIV. So I introduce Dr. Justice. Thank you for coming.
Hello. Before I start the slides, I wanted to just make one observation when you talk about complex chronic disease, which is a concept, as you've already heard, that geriatricians have been thinking about for a long time. The more general model is that there is no primary disease, that multimorbidity occurs and people have a number of different conditions which all affect their life and health. Another model is one in which there is a primary disease that drives a great number of things that happen for an individual, and it is then complicated by comorbidity. I would propose to you that I think HIV infection is that kind of a condition, much like cancer is often that kind of condition. That HIV continues to play a very major role in what happens to the people who have HIV infection, even after they get treatment. But there are many comorbid conditions that we have to consider and integrate into their management. And that might have some implications for who should be caring for them. Oops. So I want to make 4 points in this talk. People are aging with HIV and older individuals are becoming infected. AIDS conditions are less common and variably associated with outcome. Non-AIDS disease, or comorbidity, is influenced by HIV treatment and behaviors and conditions associated with HIV infection. And most importantly, we need a new paradigm for care of those with HIV. People are aging with HIV and older individuals are becoming infected. This is a summary slide showing the results of data from 3 different studies published over the last several years, all showing that people are living substantially longer with HIV infection. As you can see, the mortality rates prior to among those with HIV without HIV infection are still substantially lower, but we've seen great improvement in terms of the mortality rates that we were seeing before 1999 and those that we are seeing now. And those rates are continuing to improve. However, and I think this is very important for us to keep in mind, life expectancy is not normal. I think you saw on Dr. Fried's slide that the average life expectancy at birth is about 78, 79 years. People with HIV are not achieving that kind of life expectancy even under the current management strategies. However, how much additional life they have left has a great deal to do with what CD4 cell count they have at the time they start therapy, and I think that's something we have to keep in mind, that CART therapy drives aging with HIV, and therefore it has to be front and center with respect to how we manage this disease. A 20-year-old who starts treatment with a CD4 count less than 100 is expected to live to be 52 years of age. That same individual who starts with a CD4 count greater than 200 is expected to live to 70. Similarly, a 35-year-old who is newly infected and initiates at a CD4 count less than 100 will live to be 62. If that same individual starts at a count greater than 200, their life expectancy is to 72 years of age. So these have very major implications with respect to what our patients will see in front of them when we start them for therapy, and that's why diagnosis and early treatment is very important. You have all seen this statistic. Here's another piece of data to look at, and this is data from the Centers for Disease Control. As you can see, not only in New York, but in the country more generally, people are living with HIV, but also people are becoming infected with HIV as they age. So the prevalence of people who are 50 and over who newly present is shown over here on the on your right, and you can see that that rate has been going up annually for a number of years. The CDC hasn't released the more recent data, so this data goes up to 2005. I do a lot of my research on veterans who are aging with HIV infection, and in the VA nationally, we are ahead of the curve. That has to do in part with how one qualifies for VA care. The predominant population that we're caring for now with HIV are those from the Vietnam era, and of course they are aging, whether or not they have HIV, and so some of them get HIV as they get older. But in fact, in our population, the prevalent age and the incident age are almost the same, which I think is really striking, and suggests two things. One is the VA may not be a bad place to look to try to begin to understand at least some aspects of this epidemic as people are aging, especially among men of color, not so much among women. But in addition, it suggests that as the prevalence goes up, incidence will almost certainly go up, because as has already been said, older people do have sex. Age-associated response to CART. With respect to the viral response, older individuals have a better virologic response. This is almost certainly explained by greater adherence, and in fact that was shown in a paper by Silverberg that's been recently published, that after you account for the improved adherence that older people achieve, in part because many of them have their lives a little bit more together than some of the younger patients, you account for the improved virologic response. However, and concerningly, their CD4 cell response is not as brisk. At 1 year, their improvement is not as good as people who are under 50 years of age. And at 3 years, it's similar. So it takes them 3 years to get to where the younger individuals are in the first year of treatment. And keeping in mind that these individuals tend to adhere very well, it does suggest that their immune system isn't quite as robust in its response to treatment. I think another important observation is that AIDS conditions are less common, and they're variably associated with mortality since the advent of HAART therapy. This is data from the ART-CC, which is a multinational cohort collaboration. So this doesn't represent one cohort. This represents quite a number of different cohorts putting their data together. And it's looking at the incidence of AIDS events after initiation of HAART therapy. As you can see in the first figure here, AIDS-defining events in the first 3 months of therapy, there still are a fair number of events. And the particular events are listed over here. But what's important here is you still see a fair prevalence of incident events. But as you go out after 3 months after initiation, you see very few AIDS events. It's not that things aren't happening for people, but they aren't the AIDS-defining illnesses that the CDC describes. Further, these AIDS events are variably associated with CD4 cell count and survival. I think probably the most remarkable thing is the event that has the least strong association with low CD4 count, which is non-Hodgkin's lymphoma, has the highest association with mortality, just to give you a flavor. So just because something is associated with occurring at a certain CD4 cell count doesn't necessarily tell you how serious the event is with respect to mortality for that patient. Non-AIDS deaths are much more common. And I put non-AIDS in quotations for reasons that will become clearer later. This is, again, a summary of data from a number of different studies in a number of different locations, all reaching a similar conclusion, that if you look at what appears to be the immediate cause of death, at least based on death certificate data, and the death certificate data is by no means wonderful, but it's one source that we have. Those deaths were not from immediately obvious AIDS conditions. They were instead associated with liver disease, alcohol abuse, vascular disease, cancer, pulmonary disease, sounding much like the general medical population, not necessarily those with HIV infection.